Early on in the chapter, when we introduced the innate immune response, we said that sometimes when pathogens breach the tissues, they can get into the blood. And in that case, as far as an innate immune response, we have one of our complement pathways that can really help us eliminate pathogens. So we're going to sort of introduce the alternate pathway for complement activation in this chapter, really where it belongs, because it's truly an innate function. And we're going to talk about the classical complement pathway when we get a little bit more into humoral immunity, because as you know, that relies on antibodies such as IgM and IgG. Complement are really kind of cool. I know, a lot of students really don't like complement just because we were all forced at some point to memorize these pathways. So we have all of these interacting proteins. They get released into the blood. They act together to sort of create this domino effect where they assume sort of enzymatic activity. They can cleave some of the other complement proteins, ending in what we all know as the membrane attack complex, which just sort of sounds really sort of cool. We know that there are 3 different pathways. We said we're going to deal with sort of the alternate pathway in this chapter, the classical pathway in an upcoming chapter, but there's also an additional pathway of complement activation called the mannose binding pathway that we're just going to sort of mention but not really focus on here. As I mentioned, there are 2 pathways of complement activation that are considered part of the innate immune system. There's the alternate pathway that we're going to focus on here in just a little bit, and there is the lectin binding or mannose binding pathway that we'll talk about briefly, but we're really not going to focus on. The mannose binding pathway does activate through sort of the classical complement pathway, but does not use antibodies, so it's considered really part of the innate immune system. It is activated when mannose binding lectins bind to carbohydrates that are on the pathogen. So they can essentially set off this cascade of interacting proteins without the use of antibody. The alternate pathway is the more primitive of the pathways, and we're going to walk through this pathway in just a little bit, but the alternate pathway is sort of set off by bacterial polysaccharides, by LPS. Essentially, those molecules are really sort of important stimuli for activating the alternate pathway, and as I said, we're going to walk through how that might happen in just a second. I'm guessing when you guys first learned about complement, as when I first learned about complement, you were forced to memorize the entire pathway of complement activation for both probably the alternate and the classical pathways. We really don't have to do that for USMLE, but what's really, really important for USMLE is that you understand the functions of the complement proteins. That's going to be really high yield. It's going to be important for the exam, but it's going to be important for life too. Regardless of the pathway of complement activation, so regardless of whether it's alternate or classical, we are capable of generating all of these complement proteins that we're getting ready to talk about now. Now, we're going to start sort of at the right and work our way back, but I know probably when you guys learned about complement, when I first learned about complement, the only reason I actually had buy-in to learn about all of these different activation of proteins was because it ended in something called the membrane attack complex, which really sounds sort of cool, right? You have all of these interacting proteins that come together and they blow stuff up. How cool is that? Well, it is pretty cool, except for I feel like maybe I was a little bit misled when I first learned about this, because it was all like, and then it blows up the cells and it's really, really important. And then I got my PhD in immunology and I started diving a little bit deeper into this complement pathway. And I realized that if we're looking at all of the different types of pathogens, let's take a look at gram-positive bacteria. Do we think that gram-positive bacteria with that nice big thick layer of peptidoglycan are really susceptible to complement lysis? No, not so much. So complement cannot kill gram-positive bacteria very well. Well, let's take a look at gram-negative bacteria. Gram-negative bacteria with all that bulky lipopolysaccharide, how effective do we think complement is at lysing gram-negative pathogens? Well, you guessed it, not so well. However, there is one pathogen or one sort of genus that we talk about when we get to conversations about the membrane attack complex, and that is Neisseria. Neisseria have a modified form of lipopolysaccharide called lipo-oligosaccharide. This makes them really sensitive to complement-mediated lysis. It's one of the high-yield things they typically will ask you about on USMLE is that you have a patient that has recurrent Neisserial infections. Now, yes, it could be gonorrhea, it could be meningitis, but quite frankly, Neisseria gonorrhea, recurrent infections with gonorrhea, you wouldn't just automatically necessarily assume that you had a MAC deficiency. But if you had a patient that had Neisseria meningitis more than one time, you are probably in your brain hopefully going to go to the fact that perhaps that patient might have a deficiency in any one of those membrane attack complex proteins. Okay, so the membrane attack complex, while sort of cool, is not the most important thing that the complement activation pathways do. So if we go back now to number 1 and number 2, these are sort of the most important features of complement activation. Number 1, one of the major functions of the complement pathway is in the acute inflammatory response, and they have two major roles here. The first is as a chemotactic molecule to recruit inflammatory cells to a site of inflammation. That is accomplished by some of these A proteins that you see here, but most notably C5a, as far as a chemotactic molecule. They also function as what we call anaphytoxins. And anaphytoxins are sort of really cool. They actually bind to complement receptors on the surface of mast cells, and they cause degranulation without the addition of IgE. Now, it really sort of makes sense if you all put this into perspective. If we're looking at a type 1 hypersensitivity reaction, we get this degranulation, but it was all sort of misguided, okay? But when we get degranulation during an actual inflammatory response, those mediators such as histamine, prostaglandins, and leukotrienes are really all inflammatory mediators. They help with vasodilation, they increase vascular permeability. We're really sort of all focusing on that inflammatory response that hopefully can help us eliminate pathogens. So one of the major functions of the complement proteins, and again, you need to know specifically what these are, C3a, C4a, and C5a, function in acute inflammation. The second very important function of the complement proteins are really in elimination of pathogens. And the protein that you need to know for this particular function is C3b. So that's a non-negotiable. We have to know that C3b has two major functions. Number 1, it can help with opsonization along with another molecule that Dr. Ali is going to talk to you about in just a little bit. And it is very important in eliminating immune complexes. Okay? So C3b can eliminate bacteria through opsonization, or can eliminate bacteria that are trapped within immune complexes. What's really important about that C3b is during times where we find ourselves having a lot of immune complexes, so we have immune complexes in excess, which we can have during certain infections like post-streptococcal glomerulonephritis or an autoimmune disease like lupus, we sort of exhaust that supply of C3b because it's constantly removing these complexes until that supply runs out. And then we have to concern ourselves with type 3 hypersensitivity reactions when those complex sort of wedge their way into small vessels and get trapped in other tissues. So just sort of an overview again of the functions. Functions are super high yield for complement. We need to know the complement proteins that function in acute inflammation, which are C3A, C4A, and C5A. We need to know C3b as a complement protein that helps us to eliminate pathogens and immune complexes. And we need to know that the MAC, membrane attack complex, which are complement proteins anywhere from C5b all the way to C9, are come together basically to help generate that membrane attack complex that really is only super important in helping us clear Neisseria infections. Now, during autoimmune diseases, I'll tell you that the membrane attack complex is pretty easily can handle red blood cells and other cells, and can be very problematic during those types of disease. All right, so let's take a look at the alternate pathway for complement activation. As I promised you, you do not have to remember all of the different proteins that are involved here, nor the order with which they happen. This is when I started to get a little bit crazy in school, when we started to get into the C3BB, 3B, BB, 3B, BB, which never made any sense to me at all. So we can just sort of laugh at that one and not memorize that. But the alternate complement pathway essentially initiates when C3 spontaneously lyses in the serum. And if C3b finds its way to the surface of a pathogen, it can actually initiate this alternate complement pathway. Once that happens, what I want you to know is not necessarily the order in which this happens, but that all of the major proteins that we talked about as far as being essential for you to know are all generated regardless of the complement pathway that we're talking about. So, for example, we see that we have lots of C3b generated here. C3b, of course, remember, is important for removing immune complexes and helping with opsonization. We also have our anaphylotoxins and our chemotactic molecules here, such as C3a and C5a. And of course, like any good complement pathway, this pathway ends in the formation of that membrane attack complex. So again, don't memorize the pathway. Know that it is part of the innate immune system. Know that the important proteins are generated here, and don't focus on memorizing the order in which those proteins occur.
It's time to go a little more in depth about the acute inflammatory response and really look at some of the other players, including the phagocytes and the different cytokines that are produced by the phagocytes that are going to contribute to the overall inflammatory state. I do not want you to forget, though, that Dr. Moscatello was stressing to you the import of those anaphylotoxins in producing inflammation. And at the end of this section, what we're going to do is put everything together that both she and I have gone over. So this inflammatory response is dependent upon the damage that is incurred by the vascular endothelial layer. When you disturb the vascular endothelial layer, yes, you actually activate the complement pathway, and that would be the alternative complement pathway. In addition, you are going to have the interaction of your phagocytes that are already resident in the tissue, those being the macrophage and the dendritic cells, and they are going to respond by releasing a series of cytokines and other inflammatory mediators that are going to act locally. Now, the three most important cytokines at this point are collectively referred to as our endogenous pyrogens. Those are going to be IL-1, IL-6, and TNF-alpha. Now, all three of those cytokines have overlapping activity, so I like you to think of them as a group. But if you ever get down into a question and you notice they're asking about something very specific. Let's say they're asking, what is the major cytokine that induces fever based on its interaction in the hypothalamus? Well, I want you to think IL-1. When we get a little further into this and we start talking about the activation of acute phase proteins, which are produced by the liver, I want you to think more about IL-6, because IL-6 will be released into the bloodstream, act on the liver, and the liver in turn is going to start producing those acute phase proteins. One of those acute phase proteins, Dr. Moscatello has already taught you, that mannose binding lectin, that's going to activate the second complement pathway. More clinically, something that is going to be produced is C-reactive protein. And I'm sure anybody who's had any clinical experience at all, which should be you, realizes that C-reactive protein is a direct effect of an inflammatory response. So if you see elevated CRP, you know you have an inflammatory response occurring. So let's go back to what is happening locally. Just to reiterate what Dr. Moscatello and I have both said now numerous times, neutrophils are going to be the first white blood cells that are going to be transferred from the bloodstream into the site of infection. Once the neutrophils are in there, and we're going to talk about how the neutrophils get in there, they're going to actually release their own mediators, which are going to then call in the other white blood cells, like our monocytes, which will differentiate into macrophage, eosinophils. So all of this is happening within the first 6 to 12 hours of an inflammatory response. To best explain how a neutrophil or any of the other white blood cells are able to move from the bloodstream into the site of infection, we have to familiarize ourselves with the process of extravasation. Extravasation is going to be comprised of 4 steps. The first, referred to as rolling, where the white blood cells slow down. The second step, activation of the white blood cells, is going to be driven by chemoattractants, in particular the chemokine IL-8. The third step is going to be where the cell stops moving and arrests its motion, so it is able to then go to step 4, which is the migration from the bloodstream into the tissue and ultimately to where the infection is occurring. Don't underestimate how important this process is, for this is one of the more higher yield points that are going to come up, especially when you start talking about the clinical presentations that are associated with defects in the process of extravasation. And we're going to get to that in just a couple of minutes. So I would ask that you feel extremely comfortable with the various steps. So let's talk about what occurs and the details of what occurs. So please remember that in response to recognizing pathogens, cells like macrophage and dendritic cells are going to start producing lots of cytokines, that IL-1, the TNF-alpha. Those are going to act locally, especially on the endothelial cells. The endothelial cells will respond to those cytokines by increasing their expression of E-selectin on their surface. The E-selectin is extremely good at interacting with a mucin-like cell adhesion molecule that is found on the neutrophil. So the interaction between those two adhesion molecules leads to the initial step of rolling. Rolling then allows for the neutrophil to check out its environment. And one of the things that it's going to encounter in the environment is due to the production of another cytokine, better referred to as the chemokine IL-8. IL-8 is going to be produced by the macrophage as well as the dendritic cells, and it actually has a twofold purpose. In extravasation, it is going to serve to activate the neutrophil by binding to its receptor on the neutrophil's surface. The activation then will allow for the continuation to the third step of extravasation, which is going to be the arrest and adhesion. This is accomplished by the neutrophil upregulating a high affinity integrin on its surface. That high affinity integrin is going to then interact with an Ig-like cell adhesion molecule and is going to ultimately stop the neutrophil from moving. And again, the last step is going to be accomplished when the neutrophil or any other white blood cell is going to be able to move from the bloodstream into the site of infection. And it's at this point that the second function of IL-8 will become great, because the white blood cells are going to move along the concentration gradient of the IL-8 to get to the heart of the infection. So why was it so important for us to learn the various steps of extravasation? Well, this is the step one, and they do like to test on some very rare presentations, and these tend to be some high yield points. With what is known as leukocyte adhesion deficiency, you have a very small subset of patients who are unable to move the leukocytes from the bloodstream into the site of infection due to a variety of mutations within that pathway. Now, there is only one that is typically tested on the step one, and that is a mutation in the common beta chain of the integrin molecule known as CD18. I will tell you, to just sort of cover all your bases, I would know both. I would know that the molecule is CD18, and I would also know that is one of the chains of the integrin molecule. As a matter of fact, it takes an integrin and makes it a high affinity integrin. With these individuals who have a defect in CD18, their white blood cells are unable to migrate into the site of infection. So as you would expect, these individuals would be highly susceptible to recurrent bacterial infections as well as fungal infections. Another thing to point out is that in addition to those recurrent infections, these individuals are unable to form pus or abscesses, because again, they're not able to get things like neutrophils into the site of infection, which is one of the major components of pus. So how could we see a clinical vignette? Well, maybe you have a child who's being worked up for a raging strep throat. And what do you expect to see? Well, you expect to see that raw, agitated throat with that purulent exudate. But here you have a child who is not making that pus to be seen. So is that in and of itself enough to get you to LAD? Well, most of the time they're going to be, I don't want to say kinder, but they might throw you a bone. And the bone that they might throw you here is that they will make reference to the fact that either the child or a relative of the child had a failure of the umbilical cord to separate. And that seems like completely off base here. They're like, well, what does that have to do with anything? That is one of the major buzzes that is going to help you get to the appropriate diagnosis of LAD. Now, I want you to be careful, because sometimes they will refer to omphalitis. Sometimes they are going to refer to the fact that the umbilical cord had delayed or failure to separate. I've seen both, so be aware of both. With the diagnosis of a child with LAD, in order to definitively say that the child is suffering from this defect, they will ultimately do flow cytometry to determine if CD18 is present on the white blood cells. So that is the definitive test. Again, I don't necessarily know that. If I were you, I would expect them to give you that information in a clinical vignette, but it might be one of the answers. How would you definitively diagnose LAD? The other thing that you should recognize with LAD are some of the treatment options. Typically, when somebody has LAD, they are going to be very successfully treated just with either prophylactic antibiotics or rigorous treatment with antibiotics. And occasionally, in children who have very severe disease, if you are able to find a match for the child, a bone marrow transplant is actually going to be curative. If you walk away from this particular lecture and you are asked in the future about chemoattractant molecules, the one that I always say you need to know solid is the IL-8. But you should recognize that there are other chemoattractant molecules that are going to be working at the same time. So again, never forget IL-8. It's your easiest go-to. Keep in mind, it is a cytokine, and in particular, it is a chemokine, and it is produced by a variety of cells, a lot of those cells which are going to be at the site of infection already. Now, after IL-8, you have a couple other ones, though, that will also help bring leukocytes into the site of infection. One of those is produced by the complement pathway. Dr. Moscatello went through a lot of effort to talk to you about the production of that C5a. The C5a, as she indicated to you, is going to be one of the anaphylotoxins. It typically will bind to the surface of a mast cell, causing the mast cell to secrete that histamine. But it can also serve as a chemoattractant. And that, again, is going to allow for the migration of the white blood cells directly to the site of infection. Another chemoattractant that's going to appear not immediately, but several hours after the initial infection, I'd say about 6 to 12 hours you might see the appearance, is leukotriene B4. Now, if you recall from your biochemistry, your leukotrienes and your prostaglandins are going to be a direct result of activating the arachidonic acid pathway. And if you're activating this pathway, it's not a quick activation. So again, you can think about leukotriene B4 as serving as sort of a later onset chemoattractant molecule. And then I'm going to tell you the last one here is my favorite, because this particular chemoattractant, it's this formal methionine peptide, reminds me of my kid. Okay? My kid will give himself away every time he is doing something he should not. And in the case of this particular peptide, this is almost like the bacteria saying, hey, check me out, here I am. Because our bacteria tend to produce a formulated methionine when they are making their proteins. Humans don't do that. So when they infect the body and they have their proteins being produced and released into our systems, it's a dead giveaway. So, like I said, it's almost like saying, here I am, come and get me. Wow, we've been through a lot of material so far together, and what's going to be really important is for us to put all of this information together, and we've done that in this particular slide. If you want to feel confident about the material, I will say if you can take this figure and walk through it and know all of the details, you are solid. So let's sort of take the time and go through this together to have an overview. So we're going to be starting here by talking about what happens when we damage our tissue. And there are two things that are going to happen simultaneously. First one is going to be the activation of complement. And I just want to say straight up, you're going to activate complement anytime you have damaged the vasculature. That's something that Dr. Moscatello spoke about. And remember, when I activate complement, regardless of the pathway, I'm going to have the same three end results. I'm going to have the formation of my anaphylotoxins, C3A, 4A, and 5A. I am going to form my opsonin, C3B, which will enhance phagocytosis. And I will also be able to form that membrane attack complex. But here what I want to focus on is the action of the anaphylotoxin C5A. C5a ultimately has two functions. The first function is going to be when it binds to the receptor on the surface of a mast cell, and the mast cell responds by secreting that preformed inflammatory mediator, histamine. This is the best monoamine for getting an inflammatory response going. And I always ask that you know, what is the function of histamine? Well, it has two very important functions. As far as local function, it is going to increase the vascular permeability of the endothelial layer. Translation, it's opening up the doors between the endothelial cells, so I can more easily have white blood cells exit the bloodstream and get into the site of infection. Now, the other function of histamine that's going to become very important when we get into our hypersensitivities is the fact that it is going to serve as a smooth muscle contraction mediator. So, I've just opened the door. How am I going to let the white blood cells in? Well, that's going to be dependent upon that process of extravasation. And recall that extravasation has those 4 well-defined steps. Well, why do I have those? Well, I have those because in addition to complement being activated, I am also going to activate my phagocytes at the site of infection, such as my macrophage and my dendritic cells. And they are going to respond by producing those endogenous pyrogens, IL-1, IL-6, and TNF-alpha. They are going to work locally as well as systemically, but let's look at their local activity. Their local activity is going to influence the endothelial layer to start expressing high levels of E-selectin, okay? That E-selectin, remember, is going to cause the endothelial layer to become sticky and allowing white blood cells to slow down and roll, meaning they have time to check out their environment. The second step is going to be dependent upon the production of the chemokine IL-8, also produced by the macrophage and the dendritic cells, and it has a twofold function. It is going to first serve as an activator of my neutrophils. And what is that activation? Well, that activation is when a neutrophil responds by increasing the level of integrin expressed on its surface. And remember, we can associate a defect with the inability to produce that CD18 with the leukocyte adhesion deficiency. That takes us to our final step here, ladies and gentlemen, where our white blood cells are going to be able to migrate, or this was always my favorite word, it's losing its popularity now, but diapedese across the endothelial layer. Once it's in the tissue, that is when those chemoattractants are going to start taking play. And remember, we've already talked about 2 really important chemoattractants, the IL-8, which is our chemokine, and we also are producing really high levels of C5a in the area. And those cells are essentially going to move to where the highest concentration of those chemoattractants are, which is where the infection was initiated. Now, I gotta take a deep breath, but I do have to talk about one last aspect. Remember, I said there's an early phase response with my macrophage where they are producing things like IL-1, IL-6, TNF-alpha, and then a few hours later, I'm going to start activating the arachidonic acid pathway. And the arachidonic acid pathway is going to produce a variety of different prostaglandins and leukotrienes. I refer to one of those leukotrienes as being a chemoattractant, okay, the leukotriene B4. But what about the other prostaglandins and leukotrienes that are being produced? What's their function? Well, I'm going to make this super easy for you. What's the function of histamine here? Well, it's the same thing the prostaglandins and leukotrienes are doing. They are going to act locally to increase vascular permeability. And when you get hypersensitivities, you're going to see these prostaglandins and leukotrienes are also going to contribute to smooth muscle contraction. So immediately, I hope you're asking yourself is, then why do I need two? Why do I need the histamine and then the prostaglandins and leukotrienes? And it's actually a very simple answer. Histamine is a short-lived inflammatory mediator, whereas prostaglandin and leukotrienes are going to be around for a lot longer to allow for continuation of the inflammatory response. And that is everything in a big old nutshell.